So, very good evening to all. I'm Dr. Shweta Gupta. I'm a clinical director at Medicover Fertility. And today we are going to talk about a very interesting topic, that's ultrasound in infertility. Next slide. It's not going. Okay. So the role of ultrasound in infertility is very important. It is not only important for the diagnosis, but also it is an important part in the treatment. So I am going to go through all the different places, and this we will discuss all options and all possible uses of ultrasound. We'll start with an ultrasound machine. What is the difference? What different thing we use for female infertility? Now there are two ultrasound by which we can see the pelvis. One is the traditional, which is abdominal ultrasound. The other, which is transvaginal ultrasound. Now, transvaginal, if we compare transvaginal with transabdominal, we find that the overall resolution of ovarian and follicular anatomy is much better with transvaginal. This has a different kind of probe which is very close to the pelvic organs like uterus and the ovaries, and it gives a better resolution and good visualization. So if we compare TAS, that means transabdominal with transvaginal, this is one of the studies which show that if we see 30% good visualization in transabdominal, then in transvaginal 80% offers a much better detection rate of even small follicles and a higher accuracy. So the advantages are that the tissue characterization is much better with the transvaginal. The probe does not require the need for a full blinding. It gives a good comfort level for the patients. The patient compliance and acceptability is my serial assessment of follicular and endometrial dynamics. It's also used in IVF for the egg retrieval. There are some problems as well, because when a sonographer initially start, they have to get used to of their orientation. It's not a big problem. Once you give a few lessons that you take, you get used to of that anatomical orientation. It also has a limited field of view, but nowadays we also have a wide scanning angle transfer. Sometimes our ovary, because they are misplaced, it may be difficult to image the displaced ovaries. Patient may find it little initial reluctance because of the probe, but if you counsel them properly and you make them understand that this is going to give you a better image, most of the patient, they cooperate. So this is my picture of vaginal probe, and how we use it is we put a gel and then we use this probe cover, which is a condom, and it is put on the probe, and again thereafter we put gel. So this is when we put the gel, we make sure there is no air in it, so that we have less artifacts. And how do we prepare for scanning? We take a brief medical history. We also do a little bit of counseling to the patients, and we take a consent that is it okay if we examine you with a vaginal probe. We prepare our probe of the instrument. We ask the patient to empty the bladder. They go to the washroom, they empty bladder, and then they are put in this position as it is shown in the figure in the picture. And then we use this probe vaginally. We can see in both the planes by rotating it 90 degrees. Now, conventionally, two-dimensional ultrasound has the ability to visualize. But the reflections are obtained in two planes. Whereas if we have 3D ultrasound, then the picture can be more accurate. The translation of 2D scan to 3D scan takes time, approximately 15 minutes. One of the new modalities in this sphere called sonography-based automated volume calculation. Now, the application of sono-AVC is employed in observation of follicle growth in controlled ovarian hyperstimulation. Now, here you can see that picture. These are the follicles, which is what we see in an IVF stimulation. There are multiple follicles, and this is the picture of this multicolored is a picture of computerized, where we have volume calculation by the computer. So what do we do when we do a fertility assessment? We'll look into different options. We start in from the, the first most important is the uterus. Then we look into the endometrium. In all this, we look into their thickness, their morphology. Even we can have a blood flow and check the Doppler. Ovaries, how they are looking, whether there is any cyst, position, mobility, and number of antral follicles, which is very important to assess ovarian reserve. And of course, the parameters, other parameters on the Doppler. Fallopian tubes. Normally, the fallopian tubes are not visible. Even the blocked fallopian tubes you cannot see on a normal ultrasound. But if there is any fluid collection in the tube, then, which is what we call it medically hydrosalpinx, then it will get visible. Then we can see the tube. Pouch of Douglas for any free fluid. So we start with the uterus, which is here what we see is a normal uterus, and this inner lining is endometrium, which varies with the time of the cycle. So if it is a follicular phase, it will be just after the periods, it will be thin. As it progresses during the cycle and it goes to the secretory phase, it can be from 7 to 14 millimeters. In postmenopausal, when the periods have stopped, it gets very thin again. This is an image of the second image is of a 3D picture. Now, when we look into the uterus, we also have to rule out any abnormalities. The different studies, like this one study has compared the diagnostic accuracy of different imaging things. Like for normal 2D ultrasound, it could be around 50 to 60%. HSG, where we fill the dye and we take an X-ray, it is about 20% sensitivity. If we use the three-dimensional TVS, the sensitivity increases to 92%. With MRI, it is 100%. So the good thing is, with the help of these imagings, we can detect these abnormalities, and we can avoid diagnostic laparoscopy and hysteroscopy, which is an invasive operative procedure. So these abnormalities are usually seen like arcuate uterus, uniconvate uterus, biconvate, septate. They can be polyps, fibroids, adhesions, and synechia. So let's see them how it looks. Uniconnuate, that means there is one hair uterus, one-sided. So in this also we have one third which have a non-cavitary rudimentary horn, one third have a cavitary rudimentary horn, which may or may not communicate with the uniconnuate cavity. Now here we can see there are two. This is a 2D picture, this is a 3D picture, and this is what biconnuate uterus is. Incomplete fusion of the uterine horns result in biconnuate uterus, and the intervening myometrium extends for a variable length from the fundus to the cervix. Septate, complete division of uterine cavity and planar surface of the uterine fundus. Arcuate, when there is a broad indentation of the fundal endometrium. The most common uterine abnormality, accounting for 77% of the uterine causes of infertility, was septate uterus. This study which said that about 77% we can have septate uterus. Now the thing is that how will you differentiate? So you can see here if it is an arcuate, this angle, if you see, it is obtuse. It's more than 90 degree. If you have arcuate uterus, acute angle, then it is more likely to be subseptate. Also, what it is between the septum and biconnuate, if you try to measure like this, you will find if this distance is more than 5 millimeters, it's more likely to be septate. If this is narrow, then it is biconnuate. So this study compared the uterine assessment imaging accuracy in septate uterus. And when comparison, it was found that the transvaginal can be this much sensitive, especially in cases of infertility and recurrent abortions. With 3D ultrasound, the sensitivity and specificity increases much higher. The other, apart from abnormalities of the shape, we can also have the fibroids which distort the endometrial cavity, which impair pregnancy rates. And most IVF studies relating to fibroids and outcome exclude patients with intracavitary lesions. Sometimes they can be small polyps, or the polyps can be bigger also. Now, how do we evaluate the uterine cavity with an ultrasound? Sonohysterography is a one where it can be done very effectively in a clinical office. So filling defects such as synechia, polyps or fibroids can be identified, and distortion of uterine cavity by large masses can be critically appraised with sonohysterography. Now, this is what we call saline infusion sonography. That means that this isotonic saline is instilled in the patient in gynecological position, and the uterine cervix was exposed with a speculum. A small Foley's catheter is introduced. As you can see here, this catheter has gone inside. The bulb is inflated with a 2 ml of sterile water, and the saline is injected. Now, after this blue injection of the saline, these structures have become more visible, and this is what happens in saline sonohysterography. Now here, after this black, this is the saline which has come out. So it also means that the tubes are patent. Here you can see that the dark shadow, which is because of the saline which we have injected, is being able to demarcate this lining of any polyp or fibroid much more clearly. Of course, when we do this, we also give them antibiotic for 5 days as a prophylaxis to prevent any infection. So Uterine assessment, as you can see, if we don't use the saline, then this is how there can be picture of fibroids. And this is of course with a saline infusion, where you can see it is clearly showing the demarcation. So with the help of saline infusion sonography, we can have much better idea of the polyps, fibroids, without taking the patient in for major surgery. Endometrium is again very important. Its thickness, its morphology, and its vascularity. So there are 5 patterns of endometrium. Any menstrual cycle, it has a bleeding, then it comes into follicular phase, and then it goes on to secretory phase. So depending upon the phase, the lining varies. Now you can see here there is little bleeding, so this is active menstrual period where this dark shadow is because of the blood. Then comes early follicular, where there is a thin lining. Now this, as the estrogen develops, it increases. It forms, this is a triple lining which is developing, early follicular and late follicular phase. You can see there is a clear development of endometrium with 3 lines. And then comes the secretory phase, which is later after ovulation. So we measure the endometrium, and for a good pregnancy, we expect them to be actually more than 8 millimeters. So when we are doing their fertility assessment, we need to check the measurement. We have to measure from here to here, and the thickness should be about 8 millimeters. In literature, if we look less than 7, we expect that there will be less chances of pregnancy. And if we have very less, that is about 6 millimeters or even lesser than that, then it further decreases, and very few cases are there where the pregnancy will be. So accuracy of ultrasonographic staging of the endometrium is quite good, 76 to 93% of sensitivity. Now suppose in this picture you can see it is very thin and also irregular. It's not continuous, it's irregular and hyperechoic throughout the cycle, and it's not even changing with the cycle. So this indicates that there is some problem. In the cavity there is a synechia or adhesions because of some past infection, which could be tuberculosis or some other infection or major surgeries, or some medical termination of pregnancy where there was an active curettage done, which has led to adhesions. That means that there is no good room inside the womb, which is inside the endometrium. In such cases, we like to do, we can of course do confirmation with sonohystrography, but we like to do hysteroscopy. That means surgical evaluation of the uterine cavity and try to separate the adhesions. Here you can see between the cavity there are this adhesion. So it's better to put that patient for surgery and then prepare the lining. Blood flow in the uterus. So the color Doppler can be used, those who have good machines, and the changes in uterine cavity, uterine artery blood flow can be assessed. In an ovulatory, there is a continuous increase in uterine artery resistance. Now there are different indexes in the machine software also, where you can calculate the resistance index, which is systolic velocity minus diastolic velocity over systolic velocity, and also pulsatility index can be calculated. If there is an absent diastolic flow of the uterine artery, that is associated with infertility or poor reproductive performance. So uterine artery blood flow predicts a hostile uterine environment prior to embryo transfer. If the PI value of the uterine artery is less than 3 on the day of embryo transfer, it suggests highest probability of becoming pregnant. There is a Applebaum scoring which has been prepared prepared to assess the endometrial blood flow and receptivity. And it is based on the zone where this is going. If it is going to the zone 1, that means the myometrium outside the endometrium. If it is going further inside, then it is zone 2, hyperechoic endometrial edge. If it is zone 3, it goes to internal endometrial hypoechoic zone. And if it is going up to endometrial cavity, it's a zone 4, which gives a better chance of fertility. Tubes, as I've said, the tubes are very important, but a normal tube is not visible. Normal tube is we cannot see on a normal ultrasound. What happens if there is a problem like hydrocephalus, that means the tubes have a fluid inside collection, then we see them. So we can see these where the wall becomes thin and they become retort shaped. It may be associated with the adhesions. You will find that there is a difficulty in even locating the ovaries. There may be slight, if there is an active infection, there may be slight pain also when you are using the probe. So there is a simple fluid collection inside. These are hydrosalpines. This is an laparoscopy picture, and these are the scan pictures. You can see how they look like a retort. Next, we move on to ovarian cause, ovary. There could be some ovarian cyst, there could be PCOS, there can be a problem with ovarian reserve. Now, we can, quite a great extent, we can assess them on ultrasound. So, ovarian volume, what we expect normally is about 4 to 5.7. If it's a small volume, then we indicate a poor ovarian reserve. But apart from volume, what is next is antral follicle count, which is very important. So here, if you see in the picture, these are day 2. These are not day 2, but we like to do the basic assessment on day 2, and we check these type of follicles. Of course, if they are little much more advanced in the cycle, they are bigger, but initially we assess them, we count them in both the follicle, and this is a very good and handy test for assessing antral follicle count. We have usually, apart from the age, apart from the basic day 2 FSH, follicle stimulating hormone, presently we assess ovarian or the egg reserve by 2 ways. One is this antral follicle count, and the other is by a hormone called anti-mullerian hormone. So AMH, but because it is not available, it will not you will not get immediate result. If you are good in ultrasound, and if you are a gynecologist, you can immediately predict that what will be her chances or what is her likelihood of getting pregnancy. So if you see here, this picture has a good follicle ovarian reserve. There are multiple follicles. This one, you can hardly find any follicle, 1 or 2. So this is poor ovarian reserve. Here you can see there are so many follicles. This is in excess, which we all know is seen in PCO. So by looking at the ovaries, you can give very good idea about the egg reserve. And this is very important whenever we do a fertility assessment. We can also put some blood flow and color Doppler. An adequate vascular supply to provide endocrine and paracrine signals may become a key role in the regulation of follicle growth, and normal responders had a higher peak systolic velocity of ovarian stroma vessels than poor. Women with RI more than 0.56, they take a very longer stimulation duration, and they have lower number of oocytes. This is a typical picture of PCO. You can see there are a lot of follicles and they are arranged peripherally. So this is what we call a necklace sign. Increase, if you put a Doppler, this is also increased trauma in the center, and this is typical of polycystic ovary. So if you find a patient who has irregular cycles, and if you see on the ultrasound that the picture is like this, then you can do the you can tell her about the PCOS. Follicular monitoring is very important whenever we have a patient and we have done an assessment and we want to start a treatment. We can be doing very basic treatment like we put on for clomiphene citrate, a simple first line ovulation inducing medicine, or letrose, and we may combine it with either a normal timed natural intercourse or we can do IUI. How do we do the monitoring? We do it on the day 2, day 3. We start the medication. If she's only on these medications, we ask them to come after 7, 8 days. So she can come on the day 8 of cycle or day 9 of cycle, and then we see whether there is any dominant follicle or not. It may happen that you don't find any follicle developing, then you know the problem is an ovulation in spite of giving that baseline medicine. If you find a dominant follicle, which is when we see it is more than 14 millimeters, then we monitor the growth, which we expect to increase by 2 to 4 millimeter per day. Once we have a good size, that is about 20 millimeters, we give them the trigger of FCG. I then put them for natural intercourse. We help them to tell the exact time when they should try naturally, or they can come for IUI. The other next level is gonadotropins. That means then we are giving the injections. We are giving hormonal injections. Now, this is normally what happens when we do IVF, or in cases where the response is not good with the medications like clomiphene citrate or letrozole. So in injections, we monitor them more closely. We start with the dose and then immediately on the second or third day, and then we call them either on the day 5 or day 6. We check the response. If it's a good response, in IVF, we may add another medication. If it's a too more response, then we may have to reduce the dose of injections. And again, we keep calling them every 2 days. We monitor the size of the follicles, and about 11th or 12th day, we expect that the size is more than 17 millimeters, and then we give the trigger in, and we plan the egg collection procedure after 36 hours. But if this is an IUI cycle or it's an ovulation induction, then how do we predict ovulation? As I've said that once the size, the dominant follicle is more than 14 millimeter and we are expecting 2 to 3 millimeters per day increase in size, we call them on a regular monitoring. We can prepare a follicular monitoring chart where we write the date, we write the size of the follicle. And ovulation is expected about between 18 to 24 millimeters in most of the cases, unless there is some very rarely we have premature rupture also. But this is a big follicle, and there is a good sonolucent halo, cumulus-like shadow. If you put a color, you will see the vascularity 3/4 of the follicle. And at the time of ovulation, the study says that usually the dominant follicle mean diameter is 21 millimeters. But rarely we can have that there is no rupture, and that's a condition called Routinized unruptured follicle, where the persistent follicle which has a thick walls, there is a progressive loss of cystic appearance, the thick echogenic endometrium, and you will not find any fluid in the pouch of Douglas because the follicle hasn't ruptured, the fluid has not gone into the pouch of Douglas. Now, this is an hemorrhagic cyst with a lacy or reticular internal echos. And also the corpus luteum where you can see this is a ring of fire, the color Doppler. If you put, you can see a lot of color along the periphery. Endometrium. Now this is quite a common in females where they have very painful periods, and you can see they have this ground glass appearance of the cyst. Of course, you have to measure the size of the follicle, but this kind of appearance is suggestive of endometrioma. It has thick, shaggy walls. It may be with or without septate. Now we come to ultrasound guided procedures. If we are doing IVF, then we need ultrasound. Without that, we cannot do the egg collection, though earlier days we were doing it with the laparoscopy as well. Now here, if you see this picture, these are the ovaries, this is a stimulated ovary. This is the transvaginal probe, which we have put it in the vagina, and it is attached with this needle. There is a long needle which goes, which is with the help of ultrasound, we put it in the follicle, and the suction pump is switched on. So the follicular fluid is um, sucked in and is collected. Uh, it is collected in the tube, and this tube is then further given to the embryologist for looking under the microscope for eggs. So I'll just show you the picture of, this is the ultrasound which is in the OT, where this is a needle which is going in. It also has a etching around the tip of the needle, so it enhances the visualization. This has already gone in here in the follicle, and once we switch the suction off, the fluid is sucked, and one by one all the follicles, the follicular aspiration is done, and this fluid is given to embryologist so that it can be assessed under the microscope. And then in the lab, egg and the sperm which has been collected by the husband is mixed in the lab, and the embryos are cultured for 3 to 5 days, and then the best embryos are put back. So embryo transfer again needs an ultrasound, and this is the picture of ultrasound here, transabdominal ultrasound, where we have a catheter. So first the catheter is introduced. The inner catheter is, the embryos are sucked in the inner catheter by the embryologist, and it's given to the clinician, and with the help of ultrasound, with the help of this catheter, which is guided by ultrasound, it is placed here, which is about 1.5 centimeter below the uterine fundus. And this is how embryos are placed back in the uterus after their fertilization of the egg and sperms in the lab. And this again requires for better results an ultrasound machine. Sometimes when we have given a high dose, or as a part of ovulation induction, especially when we want super ovulation, like in IVF procedure, the body may respond too much, and there can be ovarian hyperstimulation, which means there you can see here, this is a stimulated ovary. Some of the eggs have been already collected, and these are some leftover follicles, but there is a lot of fluid behind the uterus. So it has led to a excessive response of follicular ovarian superovulation, and has resulted in hyperstimulation. Now this again is with the help of the diagnosis, requires help of ultrasound. Male factor. So male factor contributes to fertility in about 50% of couples. Most important test is semen analysis after the basic history and examination, but ultrasound is also helpful. A scrotal ultrasonography can detail to the detailed examination of the testis. It can assess the presence or absence of varicocele and also identify any content of the spermatic cord. Transrectal ultrasonography can visualize the excurrent ejaculatory ductal system. So you can see here this is an ultrasound image and the testis can be evaluated. The peritesticular structures such as varicocele, epididymal abnormalities and visualize the secondary changes associated with it. So this is a good normal testis, and then there is a small testis here with an abnormal texture and reflectivity in this picture. And normal total volume we expect of both the testes together is more than 30 mils, but a single testicular volume of about 12 to 15 millimeters considered normal. So scrotal ultrasonography can detect pathologies like cryptorchism, atrophy, torsion, infarction, inflammation, mumps, tuberculosis, neoplasm, trauma, microlithiasis, hydrocele, varicocele. Now this is a picture of a transrectal ultrasound which is good for imaging of the prostate, seminal vesicle, vas deferens. And it is the modality of choice in diagnosing congenital and acquired abnormalities implicated in the case of obstructive azoospermia. So the patient is put in a left lateral and sonography is done. So it is indicated if there is a low volume azoospermia with normal testicular size and consistency, in low volume severe oligospermia, or when there is an abnormal digital rectal examination. And there are some other relative indications like normal volume azoospermia or severe oligospermia with normal testicular size and consistency, severe motility defect in the semen test, ejaculatory problems and ejaculation, painful ejaculation, retrograde ejaculation, hemospermia, suspected genital duct abnormalities, hypospadiasis, or unilateral non-functioning or absent figure. And of course, we can put color here also. If there is an increased RI and PI of capsular branches of the testicular arteries, we can predict the testicular microcirculation. Impaired spermatogenesis may result from the defective energy metabolism in the microcirculatory bed. So this is a serpiginous and equatubular vessels of a varicocele. So in conclusion, the transvaginal sonography is a good anatomical and even better physiological information than traditional procedures in females. It aids in the diagnosis of uterine, tubular, and ovarian abnormalities. An ultrasound-based approach in basic infertility investigation is less time-consuming, less expensive, more acceptable, accurate, and cost-effective in diagnosis and thereafter treatment with its assistance. The other concept which is also important is the one-stop fertility assessment. It is based on the principle that since so many years the couple has been waiting for for the child, and they will absolutely like it if some reasonable plan can be given with the shortest time. So as you have seen that in ultrasound can be used to know lot of steps which are causing lots of the factors which are causing infertility in a very short time. It can be carried out in one place. It saves the couple and also the professional valuable time as well. It is less expensive Then if you compare with the big operative procedures like laparoscopy, hysteroscopy, it is quick. In fact, if you do it in 1 hour, a possible management plan can be outlined at the end. So it is comprehensive, cost effective, and minimally invasive. It has got a very high patient satisfaction rate. So if we have two things, an ultrasound wife assessment and a semen test, this can give us a lot of information and we can start some basic fertility treatment. What you need is a good ultrasound. Even with a 2D you can start. If you have obviously more infrastructure, 3D is helpful, and you can, even with the help of the ultrasound machine 2D, you can have assessment of tubal patency. Now it has been argued or debated what is the best time if you can call only once the patient. Some people say day 2 is the best, but for, of course, for starting the treatment, that is what it is considered. Day 2 or day 3 of the cycle, the patient should come. But if it's only assessment, then probably day 10 and 12 gives a good assessment, because it will help us to know not only the egg reserve, but also whether there is a good dominant follicle formation or not, so that you can know that she is ovulating or not. And also the endometrium, not only the uterus, but the endometrium has also developed as it should be in the periovulatory. So we can measure the size, we can check whether it's a triple line or not. It allows us to know not only the uterus and endometrium, but also ovaries or good dominant follicle is there or not. Now, as far as the tubal factor is concerned, then with the help of saline, you can, or hyposy, you can do this kind of tubal patency test right there in your ultrasound room. And you put the saline, you see whether there is a sparkling fluid on both the sides and ultimately in the pouch of Douglas, and you can say that yes, the tubes are patent. So with the take-home message, I would say that it is now well established that the ultrasound, diagnostic and therapeutic ultrasound is now indispensable in the investigation and management of infertility. So with this, I'll end this session, but of course, I think next time maybe we can have some videos also. I would now take over some of the questions which we have. So there are some questions in other languages also. And there is one question which is that uh, though you have to the gynecologist, whether they can do the ultrasound. Yes, this kind of ultrasound, especially the transvaginal probe, I think ideally all the gynecologists who are doing the fertility practice, they should do it, because for sending the patient for an ultrasound and then getting half information is not appropriate. It is better to scan the patient yourself, take all the information and make a quick assessment and do the treatment. I think someone wants to ask about the ovulation. Yes, it's a very important. I think this is the most practical use of ultrasound or the follicular monitoring, what we say, that we scan and we check the size. As a baseline, we can advise, when the patient is going to get ovulation. That window, we can tell the patient, so they can try naturally, or if there is a problem, then IUI can be easily done in OPD. So for ovulation, it is Very important that, and it's a very good test for ovulation. Okay, so we have a lot of other messages. I think that is all. So we'll end this session here, and of course, if required, we can organize in next session some videos also, dynamic thing. Someone has written that TVS is not available in Afghanistan. I think it's just a probe. If you have a basic machine, then I think if you find out, it might be available. But if yes, if it is not available, then you have to use the transabdominal, and at least you can have some idea about the ultrasound. You can also see the ovaries, and I mean, definitely the resolution, the information which we get in transvaginal is much higher. And it might be now available there, because I think it's been there now for almost 20 years. But if it's not there, then of course you see with the transabdominal, and you can see a good follicle. You can see the major, abnormalities, and you can see the endometrial thickness, whether it is growing or not, and what is the size, and make some provisional diagnosis with that. Anything else we have? For follicular assessment, is it better to do perifollicular blood flow or ovarian stroma Doppler? So yes, it is important to do the, see, the first is for the size is very important. Of course, you can do the perifollicular blood flow also, that is more important. And along with that, you can see the ovarian stroma also, but perifollicular fluid blood flow will give you better prediction. Um, so, and somebody has written which patients there are contraindication to hysterosone. Now, hysterosonography, see, most of the patients are able to tolerate it. It's like a normal vaginal examination with a probe, but some people might find it little uncomfortable, because you have to be very careful. You have to use a small speculum. You use the small 8F size of the Foley's cannula, and do it very gently. If you feel, you can even give some kind of analgesic, pain relieving medications half an hour before you do this procedure. And if you counsel the patient, because it might be very, the ladies might get very stressed just seeing the probe itself, and that you are going to do something when the patient is away. So if you counsel the patient appropriately and just tell that little bit saline is going to get injected, and we will do an ultrasound, they will understand, they will cooperate. And as far as the contraindication is, so any history of recent vaginal surgery, they will not be able to tolerate. So you will get to know in medical history whether there was any operation. In cases where there is a vaginismus, and the lady does not allow normal vaginal examination, again transvaginal will be difficult. And the contrast, if there is any history, you can use the simple saline. In those cases, you get reasonably good information. You don't need special contrast for that. So, see the arcuate, there is a question, what is the difference between arcuate and septate? Septate is when there is a septum between in the cavity. Arcuate is just a bending of the uterus, which could be a normal, modification which comes in a normal weight. So you don't have to do anything for an arcuate uterus. But for a septic, you may have to do a septal resection, especially in cases of long prolonged history of infertility with especially recurrent miscarriages. Okay, so with this, I think we will end this session. And if there are any more questions, you can always drop a message to us. We will get back to you. Thank you very much.